All right. Thank everyone for attending this morning. I know in some areas of the state the weather is not cooperating with us very well, especially here in the Baton Rouge area. But we want to thank you for joining our first virtual webinar that's bringing our communities together. You know, we work with different communities across the state, and typically we host quarterly meetings in each community individually, but we thought it'd be a great idea to have one big meeting and do it virtually so that everyone can, hopefully attendance will be there for those that can't make it to the meetings, and that we can use this opportunity to share best practices across community lines. We can also use this opportunity to talk about things that may be a barrier, an issue, or troubling us, and hopefully someone that may live on a different area of the state says, yes, I've encountered that. Let me tell you what we've done. So as we go through this presentation, we're going to talk a little bit about in the presentation what's going on in the state, some of our rates, how we're moving, some of our goals. We're also going to identify some interventions that some communities have done and providers have done that have been successful. Some of them are homegrown type things that they've developed. Others are interventions that are very easily adoptable, that anyone can adopt, because you know, any little thing helps to improve the population health and reduce readmission rates and improves medication safety, which are our goals. So after the presentation today, we're going to open up a time of sharing and discussion. During the presentation, all lines are muted for participants, but afterwards, we do ask some favors. We're going to unmute everyone's line, so we do ask that you keep your line muted from your personal phone or wherever you're calling in from, so that we will not have a bunch of people talking on top of one another and hearing other things that's going on. Secondly, as the presentation is going on, you know, one of the biggest components is the sharing part at the end. So be thinking about something that you've done in your facility or in your community that you think was successful and that others could benefit from. And as you think of things, type them in the chat, because when it's over, we'd like to call on those that are in the chat, you know, to call on you individually so you can kind of tell what you've done, and then we'll allow questions that people can ask, questions they may want to ask you about it. In addition, if you have something that you would like to see if anyone has any solutions for or experience with, then again, type that in chat. Hey, I have something that we're dealing with here that I'd like to, you know, find out if others have encountered that. So we're going to use what's in the chat box as a means of kind of getting the conversation started and trying to keep it organized. So again, after it's over, everyone will be unmuted, so we do ask that you mute your lines and then just kind of follow the process like that. Okay, we are in our 11th contract with CMS. Typically, our contracts in the past have ran for 3 years, and so a lot of you guys have already worked with us. Y'all been involved in all the other tasks or all the contracts that we've been going through. This contract began in August of 2014, and this contract is a 5-year contract. Some of our goals are the same that we've had in previous contracts. We're looking to reduce readmission rates and reduce hospital admission rates, and we want to reduce those by 20% by 2019. CMS also wants to look at community tenure, which is how many days a Medicare beneficiary actually spends in their home. So they want to see that number increase by 10% by 2019. In some of our educational, you'll notice that we've been hitting also adverse drug events. That is part of our contract this time, that we want to reduce the prevalence of adverse drug events. Now, these AEDs pertain to the 3 high-risk meds, or what we refer to as the big 3, and they are opioids, diabetic agents, and anticoagulants. So our recruitment began in fall of 2014. We divided the recruitment up in what we call cohorts. So instead of just going out and getting a bunch of people to work with us, we kind of staggered it a little bit. The fall of 2014, we did recruit 2 communities in the state. Now, a community, you know, they vary in size, and we do have our analysts do a big program to determine what's considered a community. We'll pull up providers, and then we'll look at what beneficiaries go to which providers, and when they discharge them, where do those beneficiaries go back to, that type of thing. So there is a lot of statistics that go into developing a community. But in the fall of 2014, we recruited 2 communities. The following summer, we added 3 additional communities, and then the summer of 2016, we recruited our 6th community. And if you can look at the map of the state, it is varied, kind of, you know, heavy in the south a little bit, but we also have the north, the central covered, and those are our 6 communities. Now let's talk about demographics. Louisiana has just over 500,000 Medicare fee-for-service bennies. And within our 6 communities, we have recruited about 60% of the Benny population lives in our recruited communities. So, and then we also looked at one step further to see how many of those Bennies are considered to be from rural areas, because CMS, you know, statistically rural populations sometimes have poor outcomes than those living in urban areas. And so 41.2% of our 60% statewide bennies actually live in rural areas. Imagine that, in Louisiana. We'll look a little bit at how we're doing as a state, because, I mean, we work within our communities, but overall we want Louisiana as a whole to see improvement. So from the baseline data that we pulled is July 1st of 2013 to June 30th of 2014. Hospital admissions was 322. We're currently at 308, and that is admissions per 1,000 fee-for-service beneficiaries. So we have improved 4.3% from that. Readmissions, we started off at almost 61%. We're down to just under 58%. We want to get to 48, and then we've improved 5.76. Now, again, that readmission is not a rate. It's per 1,000 Medicare bennies. A lot of us think, when we think of readmissions, we always think of it in rate. What's your readmission rate? So for practical purposes for that, we've also calculated the readmission rate, which is the hospital readmissions as a percent of hospital discharges. That's how we get rate. It started off at 19.6. We're at 19.2. We want to get down to 15.6. So we are moving in the right direction there. When we look at adverse drug events, we're actually doing pretty well in the state with reducing adverse drug events. We started off at 70.7. We want to get to 46%, which would be a 35% decrease. We're currently at 53, so we've already improved almost just over 24.5%. So that's very good from that perspective. Community tenure, those are the days that beneficiaries spend in their home setting. This number we want to go up. So we started off at 33.4. We're at 334.4. We're at 336.8. So we have gone up. We just haven't gone up very much, and we're going to talk about that also a little bit. So let's look at some data by communities. Remember, we recruited 6 communities over 3 different cohorts, and we have blinded the communities. Some of you probably know what community number you are. If you do not know, most of you are probably aware, and those who don't, I'm telling you, on My Quality Insights, which is our website, you have access to pull community reports and individual provider reports. So if you do not have login access, shoot me an email after this, and I'll try to set you up and get you login access. But you can go in and you can pull reports for your particular agency or hospital or organization. You can also pull community reports. And on the top right-hand side of the community report, it will give you your community number. We've just chosen to blind it, but you can look at what's going on with community. Cohort A, we have 2 communities, and we're looking at the improvement in readmissions, readmissions, and ADEs, and both of those communities are improving well, 5.1% and 4.9% respectively for admissions, 9.6 and 7.8 for readmissions, and their ADEs are 19.4 and 32.5. In Cohort B, we have 3 communities that we recruited during that summer. The 3 and 4 are improving pretty much around the same rate as the communities in Cohort A. And actually, Cohort B, number 4, the readmission rate, they've improved 13.8%. So they've done an exceptional job in that community of working on the rate. That community does work together very well, and they've come together with multiple providers, multiple hospitals all come together in that community. And also the ADE rate for both of those look good. Community number 5 is not right now. The numbers are in the red, but so that community, if that is your community number 5, we want to encourage you to kind of dig a little deeper, look what's going on within your organization, within your community, pull some root cause analysis information out and try to start digging and asking the right questions and seeing what we can do in that community to try to get those numbers back in a positive direction. If you need assistance, please call me or Rebecca, and we'll be more than happy to kind of walk you through it and see what we can come up with that maybe someone else has done, or put you in contact with other people that may have had the same issues. Cohort C, which was community number 6, the readmission rate for them is not exactly positive right now, but keep in mind that cohort, this data that we're looking at is quarter 2 of 2016, and that cohort wasn't actually recruited with us until the summer of 2016. So this data for them is very early data, and it's really actually before they started working. So we do expect those numbers to improve. Community tenure. Remember we said community tenure was defined as the number of days Bennies spend in their home setting. So CMS says, okay, we want to reduce readmissions, we want to reduce admissions, and we want to improve community tenure. Well, I thought, and most of us think, well, that's pretty logical. If patients are not in their hospitals and we're not sending them to the hospital, then granted, they should be staying at home. So we would assume that it would kind of proportionally and relative move in the same direction. But actually, we're not necessarily finding that. Although we have improved a little bit in community tenure, it's not nearly what we would have expected given the improvement we've seen statewide in readmissions. So be thinking about, we're kind of wanting to find out why is that happening. So in part of the discussions today, if someone has an idea of possibly why, if we're reducing readmissions and we're reducing hospital admissions, why aren't more patients spending time in their home? Are we possibly keeping patients longer in the acute care setting or post-acute care, or are we utilizing post-acute care more than we did previously? So just kind of, we're interested in your thoughts on that. Again, you guys are our eyes and ears, so your opinion matters and your thoughts, because you live it, you're in the community every day in the healthcare. So this is just community tenure by by the different communities, and again, we have 6 communities, and you can see that most of them has improved. Community number 3, the rate has actually gone down from community tenure. But again, these numbers are very, they're all close. They kind of fluctuate quarter to quarter. So we're just not seeing a huge change, or definitely not the change that we would have expected in that. So now we want to, talk about what makes communities successful. You can see some of the communities have really good numbers. Some of the communities don't have the numbers that they would hope for or we would hope for. So, what are you doing in your community? What are you doing in your organization? I can tell you that successful communities, when you are involved in them or when you see what's going on, number one, they have good attendance at the quarterly meetings. They have people show up ready to talk, people show up ready to find solutions, put things in place. In addition to the quarterly meetings, the more successful community meetings, the more successful communities also hold subsequent meetings. Sometimes these vary. For example, if we have a fairly large geographical area size for a community, they may have, one large city right in the center of the community, but you have other outlying areas that have a hospital or have providers, and they'll actually get together and say, okay, we're going to participate in the big community coalition to work on things and to hear and to see what others are doing, but we're also going to participate in some individual meetings within our suburb, for lack of a better term. So a lot of times, we have communities that has an area with, there's one hospital, and so they'll meet with the post-acute care providers. They meet monthly, quarterly, however they do it, and they work on things that may affect them specific. Another way that communities work is they'll put together focus groups to work on certain areas. I have communities that have a focus group for behavioral health. We have a community that has put together a focus group for preventative health. So anything that the community identifies that says, hey, you know what, we're going to put together a little subgroup, y'all work on that on a monthly basis, and then let's bring it back to the whole group every quarter. So the more successful communities tend to do that. And I think the bottom line is people get together and talk, and I think we do that in every community, but the ones that put action behind the words and get the ball rolling and get things done, those are the ones that have seen their numbers dramatically improve. Okay, we're going to do a little poll at this time. So Lori's going to put that up there. How has your organization changed a process or has your organization changed a process or implemented an intervention to assist in any of the following? So we just want to know what you are doing out there in your organization. Have you done something that works on readmissions? Are you doing something for ADEs? Have you have anything for both or neither? An intervention, the medical definition of intervention is the act or fact or a means of interfering with the outcome or course, especially of a condition or process. That's what we're really doing. We want to improve the outcome by reducing readmissions and admissions. We want to reduce adverse drug events and, improve patient safety and prevent harm. So we're going to talk a little bit about interventions. We're going to highlight a couple, and then we're going to have a few more that we're going to discuss. So let's look at the results of the poll. Let's see. It looks like 50% of us have put something in place for readmissions. Doesn't look like, and some of us have 44% have done both, readmissions and adverse drug events. I know a lot of the participants on this call, some of you I know verbalized to me, we're doing something for medication safety and reducing adverse drug events, but it's coming from the pharmacy department. So if you know of that, not aware, or I would like to know what your hospital's doing, so I'd still like for you to maybe send me an email, just let me know. And then one person has put together, neither hasn't done anything, and that's okay too. Neither is a good place to start. That's a good starting point, and we would love to assist you and help you, so please let us know, and we will be more than happy. All right, we're going to turn it over to Rebecca Hightower. Rebecca works with me. Me and her work together in this contract, and she works with a couple of communities, and I work with some communities as well. And this is an intervention that is easily, something that should be easily available, that you can apply in your organization, and it's been proving effective. So, Rebecca?
Okay, Donna, if you'll pass the ball to me,
all right.
So I can advance the slide.
All right.
There we go. Great. Okay, thank you. Good morning, everyone. So glad to have all of you. The brown bag intervention was developed by the Institute for Safe Medication Practices, particularly for beneficiaries who have chronic conditions and are on multiple medicines that may have been prescribed by more than one physician. This is something that a beneficiary can request from their primary physician or pharmacist. It can be scheduled in advance so that enough time can be allotted. And the beneficiary brings all of their current prescription medicines, any over-the-counter medicines they're taking, herbal remedies with them to this meeting. We all know some of the stories about beneficiaries bringing in their bag of medicines, which includes pet meds and so on and so forth. And while these may not be common occasions, that may happen occasionally. But this is an opportunity to see everything that the beneficiary is taking. And it's important when setting up the appointment that it's stressed to the beneficiary they need to bring everything, because they may not know what's important. They may not realize that over-the-counter medicines can result in an adverse drug event, or herbal remedies may interfere with the efficacy of a certain medication. So for the beneficiary, they can ask questions and maybe it's a question that their family has said, you need to ask your doctor so-and-so about this medicine. So as the review proceeds, the pharmacist or the physician is going to look at the medicines in the bag compared to the record they have for the beneficiary. So we also hope that the beneficiary is using one pharmacy so that the pharmacist has a full record, and then this primary physician in their medical record should have a complete list of all current medicines. And sometimes they don't, because the beneficiaries may not feel that it's pertinent to the care from their primary physician that doctor knows everything they take. They're also going to look at the dosage, the strength of the medicine, the frequency the beneficiary is supposed to take the medicine, expiration dates. Some of these medicines are very expensive, and the beneficiary may be holding on to them in case they need them in the future because it's so expensive to replace them. They may have 2 different prescriptions of the same drug, but in different doses. And as a case manager in the hospital, I have experienced patients who have come in for an adverse drug event, typically a digitalis toxicity, where they had 2 different prescriptions for digitalis in different doses. So at some point the dose was changed. And rather than ask how they can use the medicine they had already paid for, they just took that and the new dose, which resulted in the toxicity. So these are things that we may assume the beneficiary knows, which they don't. And so the reviewer is also looking for a possible duplication of therapy. Maybe it's a different medicine but has the same action, and talk with the beneficiary about any side effects of the medicines. And they may be experiencing that but not realize it's something that they need to report. So the physician or the pharmacist, whomever is doing the review, talks with the beneficiary to determine whether the beneficiary understands why they were prescribed the medicine. You know, they may not remember, and they may not remember what the medicine is supposed to do for them. Also, does the beneficiary understand how to take the medicine, what time of day to take the medicine, whether or not to take the medicine with milk or water or food, maybe early in the morning and then wait half an hour to an hour before eating or drinking, et cetera, and whether they're aware of any precautions that are related to the medicine. One that comes to mind would be Lipitor, which is a brand name, and a precaution about eating grapefruit, which many people who've been on Lipitor or are currently on Lipitor are aware of, but some are not. And then whether or not any of the medicines they are taking, and Lipitor would be one, anticoagulants would be another, understanding why or if any lab testing is required. So to be sure that the effect of the medicine is therapeutic and is doing what it's supposed to do. Also, it's an opportunity for the physician or pharmacist to encourage the beneficiary to keep a list of their current medications in their wallet, including over-the-counter products or herbal remedies, and share that with every healthcare provider. This is something that we emphasize in our diabetes self-management education classes, that every physician needs to know every medicine they take, including over-the-counter products and herbal remedies, and so everybody's on the same page. And also to encourage the beneficiary to fill all their prescriptions at the same pharmacy so that the pharmacist can have a complete medicine history and be able to act if they see a potential adverse event or side effect. And another thing that the beneficiary should also include on their list are those things that they order by mail order. Many beneficiaries are using the internet now, and they're doing mail order prescriptions because they may save money that way. So that's an opportunity to have that conversation, because that may not be something that they have on their list. They should have it. They may not realize they should have it. This is a brown bag label. So they may bring their medicines in a brown paper bag. They may bring them in a Ziploc. They may bring them in their purse. But this label can be given to the beneficiary at the time the appointment is made, so they can put it on the bag, and it reminds them that they need to bring everything. And so listed are some of the most common things that they might not, of the over-the-counter meds or herbal products, et cetera, that they may not think about bringing. This, one of the QIOs in our network uses this brown bag label. And something else that is included, and it's Delaware, which is our one of our 5 states, and they also include at the time of the review these points that they want the beneficiary to remember. So it gives the beneficiary something to take home, something to refer to reinforce the conversation from the appointment, and maybe remind them, in particular the last part, make sure you ask questions. Make sure you understand what you were told. If you don't understand, ask for more information and repeat the information back to the person who told you. Because I think as time goes on, more beneficiaries are going to be more likely to ask more questions than they have been in the past. In the past, the doctor orthopharmacist would be seen as an expert, and so we won't ask him any questions, but those of our generation would be more likely to answer questions because we are getting more education about the importance of asking those questions. Okay, I'll turn it over to Laurie now so she can advance the slides for Jonathan Lyons from the Capital Region Coalition.
Good morning, everybody. And Laurie, of course, we can skip on past the Capital Region Community Coalition here and get into that first slide. What we did is we got together one of the major hospital groups here in town and got together where we started meeting and found that there was a need for some level of communication between the hospital and the subacute provider. In this case, we really focused on home health and hospice. But the idea was to give the home health or whoever was going to follow that patient's care a little bit more information specifically on chronic diseases. We chose diabetes, CHF, and COPD. And what we did is we created a form that could be used in the hospital based on the terminology of the folks there to give us an idea of how the patient had progressed during the time of the hospital stay and what their knowledge level was, and really to focus the intervention from the home health once they actually got there. So if we'll go to the next slide, Laurie. This is actually the form, and I know it's a little bit small on your screen. We can definitely email it out to anybody who wants to see it, because obviously we want this to be something that takes off for everybody. But again, the premise being that what you would have here is the floor nurse would look through and see what was taught to the patient in those specific chronic disease areas on day 1, 2, 3, and 4 of the hospital stay, and to assign a numeric value, which you can barely see down there at the bottom, where we assigned a value to what their knowledge of understanding was. So a 1 being that the concept had been introduced, but the knowledge was extremely limited, and 5 being that a patient or a caregiver had a full understanding of what was going on with that specific part of the disease. So the idea being that the home health nurse or the home health therapist that walked into the door, they would get this on referral, and they would be able to review and see where the patient was and be able to provide as efficiently the instruction on the specific disease process that they were addressing. So again, the premise being that they could walk in there and go, okay, well, we've only got, we're going to front load, we're going to see you 3 days in a row. What are the most critical areas of knowledge deficit to focus on in these first 3 days that are going to keep you from bouncing right back to the hospital? So what you see there is pretty much what we came up with. We want to know what disciplines are involved, and then another key component down there at the bottom is if transitional service was recommended. So in many cases, an end-stage CHF, for instance, the patient may, oh, my screen just jumped for me. There, that's much easier to see. If a patient with end-stage CHF or whatnot had hospice introduced to them in the hospital, but they were not yet ready to accept that as their next step, we wanted to put something down there at the bottom where we could alert the home health agency to say, hey, we've introduced this concept, and you may want to work down this pathway. So we saw that as a potential opportunity, and what we'll show here in a second is how we collected some of the data and what we saw from it. So we'll, of course, I'm sure there are questions on the form. The form was ripped apart a couple of times by our group, and we rebuilt it a couple of times. But this is what we came out with, and we're really excited that it actually got some use. So, Laurie, if we can go to the next slide, that'd be great. So this is how we actually collected the data to see, whether or not the form was there, first of all, and then if it was helpful and if it was accurate. So over the time of the study, we looked at specific patients from a variety of downstream providers. So we found out whether or not they got the form and how valuable it was for them. So that's a brief little way of managing whether or not the tool got used and whether it was helpful. All right, Laurie, we can go one more. So what we had is we had 45 patients discharged to home health that we identified coming out of this hospital. The chronic disease tools were received on 32 of those patients, which is honestly a small miracle in itself, but 71% compliance with chronic disease handoff tools is pretty exciting for us. we found that the form was very accurate, very helpful, and then it did have a positive impact on the patient. So collecting the data in that real systematic way helped to show us all, hey, this was useful. This actually did something for us. So we'll go to the next slide, Lori. And here's what we have. So we'll look at the data from the left to right. So percentage of patients that were discharged to home health that were readmitted. So we had 45 discharged to home health, and 5 of them bounced back to the hospital at some point in that first 30 days. If you look in the center, those are the patients, the 32 that actually had the tool. And keep in mind, all of these 45 were identified as having one of those chronic diseases, so either diabetes, COPD, or CHF. And so 32 of those people actually received the form, and we see that their hospitalization rate or rehospitalization rate was much lower at 6% there. 13 people did not receive the form, and 3 of those bounced back to the hospital. So it gives us a little bit of a differentiation there and shows us that obviously with limited intervention and really just passing a little bit more knowledge from one entity to another and getting it to the downstream provider, we were able to be a little bit more effective at keeping people out of the hospital. Obviously that's what we're here to do. Everything that we've discussed so far is with that target in mind. So that's the data that we show, and we're pretty excited about, first of all, the utilization of the form, and then I know personally that our home health agency was able to follow some of these patients. And the nurses and therapists were really excited to see a little bit more information on the patient before they walked in the door. You know, we have the hospital discharge information and we have what happened to them in the hospital, but we don't always have an educational record to reference. So I believe that is the end of my slides, but let's go one more to make sure, Laura. Yep, I'm done. Thank y'all.
Okay, so next would be Linda Carter from the Greater Monroe, West Monroe Community Coalition.
Hey, this is Linda. How are y'all today? I need that Laura, one of the slides, please. Can you hear me?
Yep, you sound good.
Yeah. Can you hear me now?
Yes.
Yeah.
Okay. Okay. Well, this slide actually we collect the data. Our quality department collects the data, as you can see the top slide, and this is for our readmissions. And at the bottom, we were presented this from the LHA Research and Education Foundation, which matches similar to what we've been doing with the reduction in our readmissions of 13%. So I was just asked to try to explain what we've been doing here at St. Francis Medical Center. I took a job for the health system located at St. Francis in January of 2015, and no, 2016, sorry. It's not only been a year. You can go to the next slide if you don't mind. A lot of our information, gathering information, had to do with building relationships. There was no one here at the moment that had any connections with our post-acute areas, and so that was my first job to do, was to go out and build relationships. So I traveled to all of the nursing homes within our areas, a large part of the home health, and that included in the rural areas as well. Found that they were very receptive, talked to them about what I was going to be doing, trying to bring us all together quarterly for a coalition type meeting. And to date, we've had five meetings. This last meeting was 2 weeks ago, where the nursing homes, LTAC, and assisted living, we had over 35 people to attend. And then our home health and hospice that afternoon, we had over 25 people. So we have gradually and really consistently kept a large number of our post-acute areas. We've tried to work on several things at the beginning where we could talk about getting a response back from them quicker, that they've accepted the patient pending insurance. We're now moved up to an hour response time there for a while. Before we took over and started meeting, it could have been 3 or 4 hours at a time. So we feel like that has improved, and some of them can get us the information quicker. So we worked on that with them. We've been talking about transportation for over a year. We feel like we've got some, some real increase in interest here around in the community that we hope will give us some more areas to help with the transportation on getting these patients that are elderly out of the hospital and back to their nursing homes before 9 and 10 o'clock at night. One of the other things that we looked at was what did the nursing homes need as far as information. And so we had a subgroup that worked on that. Most everybody was pretty much asking for the same thing, and so we worked through all that. One thing that helped us bring everybody together as well was our comprehensive joint replacement bundle, which is run by Haley Hill. She is at every coalition or every community meeting. She presents the comprehensive joint replacement and any kind of update. She works individually with the nursing homes who are taking these patients and are monitoring each of these patients. So it kind of put us into a little fast cycle of how are we going to look at star ratings and quality ratings. How are we going to know who we want or who can accept these patients, especially with the second year and being able to move the patient going to a single care within a day or 2 days and not having to use the third day. So we've worked through all of that. One of the other things that we did, the hospital has SWAT meetings every day, Monday through Friday, at 9 o'clock that is run by administration. We're looking at patients that have a longer length of stay or trouble patients that were not able to move out of the hospital and be able to try to get our patients moving faster so that we don't have so many patients held in the ER. One of the other things that we started, we were not making doctor's appointments before the patient left. We were only saying get with your primary care within 2 to 3 weeks. So 3 of our larger areas have their nurses as well as their ATs making appointments for the patients to see their primary care physician, or if it needs to be to a specialist, we're getting the information that the specialist needs to be able to call the patient back. That started, we were only about 20% compliant when we started this. It is now up to 75 to 80% compliant on all 3 units. We did have to exclude the weekends as well as Friday afternoon at 12 because the doctors close up and you can't actually get the appointments for the patients. But overall, Monday through Friday at noon, we're making those patients appointments so that hopefully they're not they're able to go. We're trying to make them within 7 days, which is the national, I think, time frame. The other thing that we had in place that for about 3 months, but due to covering different positions with less help, we lost that person who was making follow-up phone calls before the 7 days and trying to remind them to go to their to their appointments, and then afterwards calling to make sure that they did and what kind of information they got. Within those 3 months, we were keeping patients out of the hospital within 30 days, and it was about a 70% success rate, which we were very excited about that. The other thing that we started pushing for, and because we knew it was important, was patient navigators in the ER. We have 2 now covering 12 hours a day, 7 days a week. These navigators are looking at the whiteboard, is what they call it, down in the ER to see what codes, whether they're self-pay, whether they're Medicaid, whether they're, commercial insurance. They're trying to hit the ones that are self-pays to try to intervene once the doctor has triaged to see why they're there, what kind of family support they have they ever gone to some of the clinics that we have offered for the Medicaid patients. The biggest stride that we've made with the navigators down there is that we've been able to transfer patients out that need to go to Conway or that need to go to the VA in Shreveport. We've made a huge difference in being able to do that. These are just some of the things that we started after I started to work here a year ago, and we are really concentrating on readmissions and trying to make sure that our post-acute areas have the same process, the same ideas that we do. They have worked very hard to keep their patients out of the ER, working with their nurse practitioners and the medical directors that are following these patients. So I believe that we have made an impact, and it does show within our readmission rate of decreasing by 13%. And that's all I have. Any questions?
Thank you, Linda.
Okay.
Thanks, Linda.
You're welcome.
All right. Okay, Lori, do I have the ball back with me?
I'll pass it to you right now.
Okay. Thank you, Linda. Thank you, Jonathan, Rebecca. And as y'all can see that some of these interventions are kind of maybe a little simple to do, and then others are more in-depth, because you need to look and see what's pertinent to your organization, what are your overall goals, what are the areas that you think are the weak areas, and that's all part of doing a root cause analysis. Another thing that I heard in both presentations is actual numbers, actual data. Jonathan said we had a 71% compliance rate about the form actually reaching the downstream provider, which, believe it or not, when the program first started, the first couple of months, there was very little compliance rate. It was probably a 10 to 15%, because we collected data and they looked at it, they was like, hey, what's going on? And so they kind of make a few little process changes to get it where it needed to be. And also I heard that Linda was saying her compliance rate of patients and the discharge follow-up and seeing doctors was like 70%. So data is very important when you put something in place, because sometimes you make a process change, you educate everyone, you implement an intervention, and you think, okay, great, well, let's watch some long-term numbers. Let's watch our readmission rates. But if you don't really know that what you've implemented is taking place on a daily basis, you can't, if your numbers don't change, you don't know if the intervention worked or didn't work, because if it wasn't implemented like you expected it to be implemented, then you can't attribute a change to the intervention. So let's take another kind of quick poll right now. And the poll is, if you have an intervention, are you collecting data? I think that's interesting. I think that's going to vary. So I'm interested to see what people are doing. And while we're waiting on that poll, I'm going to go over, there are 3 interventions that I'm just going to highlight right now. These are interventions that are on a much bigger level that organizations have developed, and they are offering these interventions at our QIN level. Our QIN is 5 states, Louisiana, West Virginia, Delaware, New Jersey, and Pennsylvania. And they're offering them at no charge. Typically, there is a charge for these interventions, but they're offering them at no charge to providers within our QIN. The thing that they're asking is that providers collect data for them. So it's kind of a win-win situation. They're offering it. We're going to collect data. We're going to send it back to them, and it's going to help them support the intervention from their end even more. So let's see the results of our poll. Have you collected data on an intervention? It looks like 19 of 25 people said yes, they have an intervention and are collecting data. 4 said they have an intervention but are not collecting, and again, 1 has not implemented an intervention, which is also okay, so maybe we can change that as well. But I'm glad to see that so many people are collecting data. From our perspective, we would love to know what you're doing and know what you're collecting, because on a random basis, CMS wants to know what states are doing, and CMS loves to see data, good or bad, preferably good, but they'll take either one, so we do like to report that to them. And so I would love to know what you're doing and what you're collecting, and see if we can, you know, everyone take a turn and share and report their data. Well, getting back to these specific interventions, the first one that I'm going to talk about is a patient activation measure, or a PAM tool. One outcome that people look at sometimes when you do an intervention that affects the patient is the patient activation measure. You know, did their knowledge increase from the intervention, or is their confidence level better? Do they feel more confident in talking to their doctor or understanding their disease process or something like that? So this tool is a 10 to 13 questionnaire, and it's given to patients. It's a very specific tool, and it will assess the underlying knowledge, skills, or confidence level, and for patients to manage their own health care. The second intervention that I'm going to talk about is a mobile app called Dose Doctor. This app was developed right here by a doctor in Baton Rouge, Dr. Dustin Williams, and we have some providers that are using this app. And the app, you download it on your mobile phone. It's typically for patients that are insulin-dependent patients, but this app will allow patients to put in a glucose reading when they take glucose, and it can be transferred to a web portal where it's seen by a physician, and the physician can make incremental changes to the insulin dose for these patients, so which is having good results with keeping patients with a much better A1C, and it's managing their hypo and hyperglycemic events. Typically, patients sometimes see their doctors every 3 months or whatever, but these patients can get adjustments much quicker. The patient's own physician can look over the results and make the changes, or Dr. Williams has offered his professional services right now for a limited time at no charge. So if there's any provider that's interested in learning more about this app for their patients, please let me know, and I'll be more than happy to get you in touch with him. The third one is a condition-specific assessment and communication tool, CSACT, and these are tools that are, communication is a big key, and I have some communities that's working on streamlining the way we communicate between providers, particularly when there's a problem, like say from you know, a nursing home to a physician, patients short of breath or have fever or whatever. And then a lot of us have used tools like an SBAR, where you do the situation, background, assessment, recommendation. Well, these are condition-specific tools where you'll have a, you know, shortness of breath type tool, or, you know, a nausea and vomiting or something like that. So, again, these tools are available for a limited time to our providers, so if anyone's interested in adopting tools like that, then let me know as well. One other thing that I want to talk about in the improvement process, and it's right now it's very big on the radar with CMS, and that is to engage patients and families. You know, for years and years and throughout this, all of our contracts, we work with providers. Providers work among themselves. You dig deep within your organization. You find areas where, hey, I think we can improve in this area. But the one thing that we realize that we're missing, a key piece to the improvement process, is to involve patients and families. We as clinicians or in the healthcare providers see things from a different perspective. We're like, hey, we want to move from point A to point B, and this is what we think we need to do to get there. whereas it's so beneficial and the impact will be much bigger if you can bring in patients and families to or have a representation, someone there to represent patients and families so they can say, hey, you know, yeah, that sounds great, but we're going to see it as this. We may not be able to understand what you're putting in this form. So we want you to embed patients and families, advisories, in your council meetings, in your focus groups, in your coalition meetings. You can do that in a community level to attend the coalitions, which we would really love to have. You can also do that in the provider level. I know of hospitals that have patient advisory councils. They use them in all sorts of activities. When there's process changes, they're involved in that. They're involved in, you know, vision of where the hospital wants to go. They're involved in their QI processes as well, again, because they see a different perspective and they can help us identify opportunities for improvement that we may otherwise miss. We do have guidebooks that we can provide for you that kind of help you through the process, you know, in selecting the appropriate advisors, and then we also have recruitment forms like trifolds that you can use. You can use our forms or you can use those to model them and create your own forms to try to recruit advisors. So at this point, we would like to open up the floor. We're going to unmute everybody's line, and we are going to talk about what's going on. So please, if someone, we're going to start off hopefully with successes. So if someone has an intervention that they've done that they think others would be interested in hearing about, please put it in chat so we can call on you.
Okay, everyone has been unmuted.
I do see a couple of questions. People have asked about their community numbers. You can pull that off of My Quality Insights, but I will also send out a community report to each community this evening. Another question is, if an organization reports an intervention and data to me, can CMS hold that information against you? No, CMS will not hold information against you. Typically, when we report it by community. Like we'll say, hey, the Baton Rouge community had this intervention, and then we just report raw data. We don't report patient-specific data either. And we aggregate the numbers. Okay, is there a nursing home out there that's done something? Or if anyone has an obstacle or an issue that they are kind of going through. I know one of my communities is having a problem with mental health. They're getting an influx of mental health patients, and they're having trouble placing them and preparing for them. And has anyone found a way to handle that?
I know for us with mental health, this is Lindsay Buford, it's still an issue. We hadn't really, it's kind of gotten worse. You know, more places have not been able to operate their normal hours. They've had to cut back on hours and days of the week. Some of our good referral places have had to cut back to 3 days a week. So they continue to get cut and have to lose some services.
So what are you doing with those patients right now, Lindsay?
Well, I'm giving them medications that'll last them 3 and 4 months. And then we give them a list of resources, all the numbers to the different, whether it's inpatient rehabs or outpatient rehabs or provider appointments. We give them a list, and we have to, at some point, put it on them to just call these places until beds open up for them. Since we are just acute crisis stabilization, our average length of stay is about 3, 5, 10 days, depending on the patient, and then trying to get them in. We're starting them on new meds, getting them back out there, but they're just, it's falling apart on the aftercare planning.
Has anyone else done anything with these patients or have an extra step that they think Lindsay could think about?
This is Dr. Holcomb. I'm in public health, not in hospitals, but the Human Service District Advisory Council has worked with the law enforcement to do specific programs and training programs to identify people that have mental health issues, to keep them from, ending up incarcerated and getting to the right services. Now, the services are an issue because I'm sure people have noticed every human service district was reduced in the upcoming budget. That's a problem. So we're not sure how we're going to address all that.
Yeah, I know this is a very, very tough one. Someone else is about to say something. Yes.
Hi, it's Lisa Stansbury with KEPRO. I just had a quick question for the group, and it might be happening in Monroe, but I'm not sure. I know that in one of my other groups in Baton Rouge, the FQHCs in the area are integrating primary care and mental health services in certain kinds of models. I don't know if the FQHCs in Monroe are doing that, but it might be something to look at. I mean, federally qualified health centers. When I say FQHCs, federally qualified health centers.
Exactly. And for those of you who are saying, well, what is that, you can Google Louisiana Federally Qualified Health Centers, or FQHC, and it will give you a list. So I appreciate that, Lisa. That would be very interesting to see what, if they have any resources or assistance that they can offer.
All FQHCs are mandated to offer not only mental health but dental services. The problem is that they have the same recruitment issues as everyone else, and so it's difficult to find personnel.
Gotcha.
For the Lake Charles area, I believe our closest one is in Lafayette, and transportation is already an issue for our patients. We just have a lack of providers as well. It's an underserved area, so that doesn't open up the opportunity for appointments very easily.
Right. Lindsay, how well are y'all having success with engaging like a family or a friend or a partner for that patient, like a patient advocate to kind of, assist the patient when they leave or at the house?
A lot of our patients in the adult population, there's a significant lack of social support. A lot of times we get a high number of drug abuse patients. They've gone in and out of rehabs, burned a lot of bridges. So it's really hard to get a family member to agree to kind of help them because they felt kind of burned by them a lot.
Right.
We do call the families, and if any contact that the patient's willing to give us, we'll call and try to encourage them to assist with it. If we notice that transportation is a huge issue, NHS is in this area, and they'll go to the patient's home. If there is a home, we have a large homeless population. A lot of our patients are just in tents or in the Salvation Army or different areas. And so NHS will still go find them, but they have to meet somewhere. They won't go meet them under a bridge or anything. They have to have some meeting places or some type of not necessarily an address, but I'm not sure how they meet up with our homeless population. But at least it keeps them from having to drive or pay a bus ticket to get to their appointment.
Thank you, thank you. I see Annette typed in about her medical directory binder. Annette, you want to talk about that some?
Hi, good morning. Yes, I'm really excited about bringing the medical directory binder to fruition. It's been in the making for about 6 years now, and it is a notebook that is designed to help the patient organize all of their information in one location. and it provides their demographic information, their med-surg history, as well as their lab, x-ray, and vision.
All together. Let's go.
Can you hear me?
Yes.
Okay. And it includes their lab, x-ray, physician consultation, legal information. I also have a physician visit checklist so they can prepare prior to their visit. Also some organizational tools in there, a 3-hole punch that is in the actual notebook so they can, you know, hole punch their information. There's education on in the notebook that reminds them and educates them on how to communicate with their doctor at their doctor's visits, just prompters and things of that nature. And I do have a website, which is www.mymdbinder.com. And so I'm hoping to present a PowerPoint at the Lake Charles location, and you know, it's really exciting because, you know, I've been in all of the positions, especially as a caregiver, realized that it's so important for the medical professionals to get the accurate information, and this saves their time, as well as, you know, it's just a win-win for everyone, the patient, the caregiver, and the medical providers.
Yes, you know, that's a very good intervention to have the patients with a medical binder, also known as a personal health record, when the patients go from provider to provider. And it also kind of enables the patient and helps in pretty much makes the patient more of an active participant when they're keeping up with their own health care.
Right, and when I meet with them, I do some classes and teaching on how to become your own medical advocate and, you know, what you need. You know, the elderly really want something tangible, something, it's, you know, something they bring with them every visit or every, you know, if they go to the ER, urgent care, or their physician's visit. Now, you know, as time goes on, I'm sure the millennials will want an app for their phone. So, you know, that is in the making in the future.
Oh, great. Yeah, you're right.
People 65 and older don't want to have it all on their phone. They'd rather be able to look at it. Well, really, maybe even younger people. I have people purchasing them for their children if they have, you know, kids with a chronic illness, or elderly that, especially if they have dementia, or they have, you know, one of the diagnoses that they're going in and out of the hospital a lot.
Thank you. Does anyone have any other information regarding personal health record or an MD binder, or any questions for Annette? I do have something that I want to throw out as well, in that, you know, we're always thinking about ways to improve patients, and I have an intervention that I would like to challenge someone to pick up. That actually I was, you know, talking with the home health agency, and they're going to do it, but at that given time they said I can't because I'm moving locations, and they had a lot going on. But we were discussing interventions and ways to patient, and there's an intervention that I would love to see taken on probably by home health, but it's an opioid intervention. And we will help you with this intervention, but what we would like to see is to try to, opioids big, and CMS realizes that it's an epidemic right now with the opioid abuse. So the intervention is going to be very simple. Basically, we'll provide some tools for you when you admit a patient that's on an opioid to educate the patient, and then downstream on one of your subsequent visits, it may be your 3rd visit, 10th visit, wherever, for the nurse, the home health nurse to count the pills. Count the pills to see if the patient's being compliant. You know, that's going to be our outcome. From an education perspective, I would love to do it a month or 2 before we implement the intervention to get some pre-intervention data, and then implement the education and do some post-intervention data. And for those patients that are not compliant, you know, we can even have one more step and would provide some educational tools that you could provide to the physician as well to say, hey, this is your patient, and then, you know, to educate them. So if there's an agency out there that'd be interested or willing to do that intervention, we would love to work with you and help you and collect data. And again, it should be something that's very simple and not very burdensome as far as time and effort. Any takers?
This is Dr. Holcomb on a different, well, it's actually all mixed up. But we have provided the local hospitals here with maps of what they call concentrated disadvantage.
Tornado, you are going to be experiencing straight one right now on our camera, and it is black. Oh. It is the sky is.
Oh, where this call is. Good grief.
We have tornado warnings out here, but it's not from my end. Go ahead, Dr. Holcomb.
Okay, well, anyway, because your high-risk population for readmissions is largely in your areas of concentrated social disadvantage, and these maps are very easy to generate from a site called Community Commons. And you can actually go on, and so if you know where the patient comes from, you can actually stratify their risk. Because if they're in these areas of, quote, concentrated disadvantage, they're going to have less access to, I mean, they're going to have less social support, less access to good food, less transportation problems, and a whole host of deals. And so you can target your limited resources to those people. And so you're going to get more bang for your buck. But, you know, there's been several studies about this, and it's not everybody that's going to have a problem. The guy who lives in his upscale, you know, I mean, there are people who are going to get readmitted because they're sick and all that. But it's so tied up with their social structure and their wealth and their educational level that you can almost predetermine the people that are going to have problems. And you alluded to the homeless population, but there's also just people who are just plain poor. So if you work with, you know, you can do this on your own, or you can work with your public health in your region, but you can actually generate those kinds of maps, and it's remarkably revealing.
That would be a very interesting to include that in our high-risk assessments.
Yeah, it's not difficult to generate them. You can actually set these things and determine if you want to include only regions that have 20% or higher of poverty, or less 20% or higher of people with no high school education. And it literally maps out the region. It's done on census tracts. It's not done on zip codes. It's done on census tracts, so it's actually smaller. Our problem in our area is that some of the parishes are so poor and the populations are so small that, of course, it's the whole place, the whole parish. But in bigger urban areas, you can actually map out the areas where you're going to have most of the problems.
I like that. And I mean, we, working for CMS, we're always looking at reaching out to the disparate population. So that would be a really good thing, especially for the urban areas, to say, you know what, if you're within the zip code, then, you know, it would be a much higher risk for readmission.
Right. And it just, because people don't have limited resources, they can concentrate their resources on those people, on those groups that are going to be the most likely to provide, you know, to result in readmission. It's a public health way of thinking about it, which is CMS is really interested in this community health concept, but hospitals have not always been real receptive because they're not used to it, not used to thinking in population terms.
Dr. Holcomb, do you know of anybody in particular that is using that?
Well, I mean, I've given it to both of our regional hospitals, and I'm not sure if they're using it or not. Okay. But I've certainly introduced it, and anybody can go on this Community Commons site and generate those maps. it seems like a logical thing to do because, you know, you only have so many people who can work on this, because all of those initiatives were interesting. I mean, they were all brown bag or, you know, whatever. They're all good initiatives. But if you have limited resources, you can concentrate on those people who are more likely to be readmitted. Exactly.
Yeah, so any intervention that may be more costly than what you have resources for, doesn't mean you can't do it, but you can still do it and concentrate on your most highest risk patients.
Right, and that's actually determined by the geography, not by what sicknesses they have and all that.
Good point. Good point.
So if anyone's interested in that site, you can go. If you have some questions, you know.
I think we lost you, Dr. Holcomb.
Go ahead.
I was saying I think we lost Dr. Holcomb.
No, I'm here.
Okay.
That would be very interesting. I see someone posted in the chat that maybe next time we do this, that maybe you can give a presentation or give a little further.
Yeah, I could show some slides on how it works because it's a very, very easy tool. It's a free tool, Robert Wood Johnson, and it's very, very helpful. It's just folks are not used to thinking in those terms.
Right. Right. And so if anyone does utilize the tool,
Pardon?
If anyone out there does utilize that tool and implement something like that, I would love to work, you know, with you in that because I'd like to get some data from that to see was it different than what you expected and how effective was it. And speaking of finding out about that, one thing I did forget to mention is that after this meeting, we are going to have a survey. I would ask everyone to try to stay on to complete the survey because we would like to know if this type of meeting was beneficial to you, you know, and what your thoughts are, to know if we're going to continue these virtual meetings or not. So does anyone else have an intervention or something that they've done that they think would be interesting for others? And look, I know there's hospitals and nursing homes and hospice agencies that have done things because I hear them in the meetings. Don't be shy.
Hey, this is Tammy with Thompson Home Health in Alexandria. We have in place what we call Care Cycle Navigator. It's a clinical intelligence software that we have for our company. And it combines daily biometric data from devices that we place in the patient's home. It's a blood pressure cuff, an O2 stat monitor, heart rate monitor, and a scale. And so we try to put this in our patients' homes that we know have a high potential for being readmitted into the hospital. So we've been looking at CHF, COPD, diabetes, chronic hypertension, and with the software, it's monitored by our team of critical care clinicians. And so if there's something going on with the patient, if there's possibly a gradual increase in weight over a couple of days, we, you know, contact the patient, contact the nurse that sees that patient so we can intervene before the patient has an exacerbation and has to go to the physician's office or has an unnecessary visit to the emergency room, possibly give some Lasix, you know, decrease the fluid on the patient. And so with these patients, we've seen a dramatic decrease in rehospitalization rates. Our 30-day rehospitalization rate is close to 7 to 9%. The national average is about 19.6%. So we're seeing where this is, you know, truly making a difference with these patients. The wonderful thing about this, if a patient's not feeling well, if they're just, you know, feeling that they're not normal, you know, they can get on the equipment, check their vital signs, because we all know that just because a patient's having a problem, it's not necessarily going to be the day that the nurse is scheduled to go out to see them. You know, it could happen any time. So we are seeing where this is making a difference.
Thank you. Yeah. I've seen more agencies adopting tools like that, and the results have been very impressive.
I will say we've been doing this for probably close to 13 years. And initially when we began, we were just collecting data, just collecting data. And, over time, monitoring that and seeing where we can intervene and getting algorithms in place with this particular software, we really feel like we have pegged it. We've served over 3,500 patients, with this, and, we've definitely seen where it's made a difference.
Thank you.
Thank you.
Is there a hospital out there that's done something? Maybe something particular aligned with your goals? No? Well, we have 9 minutes left, so if there's no one else with any other comments, I appreciate everyone that has input. I think, Dr. Holcomb, I do like that Community Commons site. I'm going to take a look at it, and Lindsay and all those that are struggling with mental health and behavioral health issues, we as a QIN-QIO, we're going to continue to look for resources, and maybe that's something we can bring up with our other 5 states and see if there's resources they've discovered that maybe is untapped down here. Again, if anyone would help me out with the opioid intervention, I'd appreciate it.
This is the bank? Okay.
But we got 7 minutes, 8 minutes, so if there's no one else, we'll go ahead and end the call. But please remember to do the survey so we'll understand what your thoughts are and what we can improve upon, what you liked, what you didn't like. And I'll be sending out your community reports this evening.
This is Dr. Holcomb. There's a lot of initiatives on opioids that are taking place all over the country, and some are quite useful, but they all stress that the mandatory use of the prescription monitoring program by all physicians, not just ER or whatever, and that is a policy issue. And so there are other things that they won't honor any renewals, the 7-day max. I mean, there's all kinds of things that are being done all over the country that are proving effective. Just a last remark.
Yeah, I totally am in favor of the monitoring database initiative, and I agree with you that it's a policy issue, and once it's made, I guess, mandatory, for lack of a better term. But I do want to encourage all facilities, if you don't know what that is, I think it's PDMP is the initial for it, but it's a monitoring database for patients that are getting opioids. And so if a patient shows up in your organization, you can log on and see when they've had their last opioid refill and how many they've gotten, so these patients are not, quote unquote, doctor shopping and getting multiple prescriptions. Someone said they think the PMP participation is going to be one of the MIPS measures too. All right, well, I appreciate everyone. Thank you, Linda and Jonathan and Rebecca. Thank you for all y'all that participated as well. We had a really good turnout today. For those of you that are participated that may not be on our email list, I will add you to the email list so that you'll get invitations to the community meetings. If there's anyone else that you think that we need to invite, please send me their emails. We are interested in the opioid. Okay, Julie, I will get back with you in that. All right. Well, thank you so much. Look forward to hearing from you, and let us know what you're doing. And again, send data, and we want to share your successes.
Donna.
Yes.
It's Rebecca. I had to dial back in. LHA asked us to share the information about the new CMS rule about emergency preparedness.
Okay, go ahead.
So I will, there are a couple of links, and then there are things that the 17 provider types will be required to do. That includes a risk assessment using an all-hazards approach, developing an emergency preparedness plan, policy, procedure, develop detailed communication plans, and establish training and testing programs. I'll send this in an email to you for your communities, and I'll send it out to mine after the call.
Okay, thank you.
Dr. Holcomb, I strongly suggest you work with your local Office of Public Health, because we do all that stuff.
Right, and that's what Cindy said, to connect with the regional coordinator for the Louisiana Department of Health and Health Standards.
Yeah.
Thank you, Dr. Holmes.
All right, thank you all.
Thank you.
Thank you.